So in this lecture we'll start with diabetic macular edema. So when macula is affected because of diabetes, it is called as diabetic maculopathy, and usually it is in the form of macular edema. So diabetic maculopathy is leading cause of legal blindness in diabetes. The diabetic maculopathy can be present in any stage of disease. It is not necessary that the patient should have proliferative diabetic retinopathy to have macular edema. It can occur in mild NPDR also. So it can be present at any stage of disease, but it is more common in patients with proliferative diabetic retinopathy. So why diabetic macular edema is important? Because the macula is responsible for the central vision. The visual acuity which we check by Snellen's chart is because of macula. So macula is responsible for central vision. It is also responsible for near vision and color vision. And diabetic macular edema may be asymptomatic at first. As the edema moves to the fovea, that is the center of macula, the patient will have blurring of vision and the ability to read and recognize faces will be compromised. So this is how macular edema looks like. In the left side, again the retina is normal, whereas if you see the right side picture, you can see that there are small yellow dots in the temporal part of macula, and you can also see that there is some swelling in the macula. So this is macular edema. So macular edema can be clinically significant or not clinically significant. So how do we know that the macular edema present is clinically significant? So if the macula is thickened at the retina within 500 micrometer of center of macula, then it is clinically significant. Or if there are hard exudates at or within 500 micrometers of center of macula, if associated with thickening of adjacent retina, it is significant. And area of retinal thickening 1 disc area or larger within 1 disc diameter of the center of macula, again it is deemed to be clinically significant macular edema. So this is the International Clinical Diabetic Macular Edema Disease Severity Scale. Okay. So this mild, moderate and severe, again they have classified in different types, in different ways, but you should know what is clinically significant macular edema. So if you do OCT of this patient, you can see that this normally you can see very clear depression in the center of macula, that is fovea, that is called as foveal contour. So in this patient you cannot see foveal contour, you cannot see where there is fovea, and instead what you are seeing is that the center of macula is swollen and there are septi here and there are cystic spaces in the macula. This is indicative of macular edema. So 90%, how to prevent diabetic retinopathy? So 90% of diabetic eye disease can be prevented simply by proper regular examinations, treatment and by controlling blood sugar. So the best measures for prevention of loss of vision from diabetic retinopathy is strict control of blood sugar, and you also need to control the associated comorbidities like hypertension and increased triglycerides. So what is the treatment of diabetic retinopathy? So basically there are two treatments. There are various treatments, but the two important treatments are either laser or injection. So what is laser? Laser photocoagulation. Where do? We do it in CSME, that is again clinically significant macular edema and proliferative diabetic retinopathy. So basically what does laser do? Let us discuss the mechanism by which this laser acts. So in PDR or proliferative diabetic retinopathy, what is the purpose of laser? We are coagulating or we are burning the retina, and this we are creating a scar. So what we are doing is we are converting hypoxic retina into anoxic retina. Means we are not doing this in the macula. If we do in the macula, then the patient will lose vision. So we are doing surrounding the macula in the peripheral part of retina, that is called as pan-retinal photocoagulation. We are burning the retina, we are converting the hypoxic area into anoxic area, because once we coagulate a portion of retina, it will not require oxygen. So what happens that because of this, the oxygen requirement of retina as a whole decreases, and then the nutrition of the or the ischemia of the macular area, which is critical for central vision, may improve because of this pan-retinal photocoagulation. And also it will reduce the formation of vascular endothelial growth factor, and it will reduce the proliferation of new blood vessels. So that is the mechanism by which this proliferative pan-retinal photocoagulation works in, or laser simply works in proliferative diabetic retinopathy. And how does it work in macular area? In macular area, we are not applying very intense burns, because if we apply intense burn in macular area, the patient will have scotoma in the macular area. The patient will lose the vision because it will coagulate or it will kill the photoreceptors. We are not doing that. Here what we are doing is we are applying mild burns to the retina or in the macular area, and these mild burns will somehow reduce the leakage from the blood vessels, and this leakage is responsible, friends, for macular edema. So once this leakage is reduced, then the patient's vision will improve. So this is how laser acts. So how does laser act in pan-retinal photocoagulation? It converts hypoxic area into anoxic area. And how does laser acts in macular area? It reduces the leakage. So there are other treatments of diabetic retinopathy also. That is, we give intravitreal injections of avastin. That is, it is inhibitor of vascular endothelial growth factor. Then we sometimes have to do surgery. So these are the other modes of treatment. So the mainstay of treatment is laser. So laser के बाद injection, और laser के पहले भी we can give injection and we can do surgery. So what stage wise what do we do? If there is NPDR, मतलब नॉन प्रोलिफरेटिव डायबिटिक रेटिनोपैथी है, तो क्या करना चाहिए? तो बेसिकली we have to counsel the patient that, see, your retina is getting affected, so you can lose vision anytime, so you must control the blood sugar, blood pressure and increase lipids if present very meticulously, and you should undergo sequential eye examination, regular eye examination at least once in a year depending upon the severity. अगर venous bleeding है patient को, तो once in a year may not suffice. You call the patient after 3 months, and we have to observe the patient. So that is the treatment of non-proliferative diabetic retinopathy. So without macular edema. So if macular edema is present, then we can do laser in the macular area, or we can give injection of steroid or VEGF inhibitor inside the eye, and this injection will reduce the amount of leakage of photoreceptors or blood vessels in the macular area, thereby improving the vision. And if this fails, we can do vitrectomy and we can peel over the membrane or epiretinal membrane that is formed. So this is how you treat macular edema. Friends, the treatment of macular edema is very difficult and very costly for the patient. The patient may have to come for the follow-up repeatedly. The patient may have to get patient may need multiple injections of avastin, or if avastin fails, the patient may need injection of steroid or Lucentis. So it's very costly treatment. So prevention is always better than cure. So this is how the laser treatment is done in this diabetic maculopathy. You see, what has happened here is there is a area where you can see exudates in a circular area, and in the center of that area there is macular edema and there is microaneurysm. So what we are doing is we are treating this area with mild lasers to reduce the leakage. So these are the laser marks, the spots of lasers which we have applied to reduce the leakage. Okay, so what is the treatment of vitreous hemorrhage? Patient may present with vitreous hemorrhage. So vitreous hemorrhage में क्या करेंगे? Vitreous hemorrhage is because of proliferative diabetic retinopathy. So what is the treatment of proliferative diabetic retinopathy? The treatment of choice is pan-retinal photocoagulation. So what do we do in pan-retinal photocoagulation? We burn the retina with multiple burns in all quadrants, superior, nasal, inferior and temporal quadrants, and this will reduce the amount of oxygen that is required by the retina. So PRP is the gold standard for treatment of PDR or proliferative diabetic retinopathy. So vitreous hemorrhage has occurred because of PDR. So we have to do pan-retinal photocoagulation. But for that for the laser to act, the media should be clear. So if the vitreous hemorrhage settles down, then we can apply laser safely. So first, if the patient comes with vitreous hemorrhage, we have to wait for the hemorrhage to settle down, then we can apply the laser. But sometimes the vitreous hemorrhage doesn't settle down within 3 months, then we can remove this hemorrhage by surgery, that is called as vitrectomy, and we can apply endo laser. Endo laser means we can apply the laser directly into the eye through a endo laser probe. So that is called as endo laser. And again, we can also give injection of vascular endothelial growth factor, that is Avastin. Basically, this Avastin drug is used for the treatment of colon cancer. So we take that drug, we dilute it, and then we inject into the eye. So that is an off-label use. And if the retina is detached, what we have to do is we have to again observe. If it is not involving macula, we just observe, and if it is involving macula, then we have to do vitrectomy with macular dissection. So this is a beautiful picture of pan-retinal photocoagulation. You see what these white marks are, the fresh laser marks, friend. मतलब लेजर करने के बाद लिया हुआ ये फंडस फोटोग्राफ है. So what we are seeing here is we have spared the area between superior and inferior temporal vessel, that is essentially macula is spared, because if we apply laser in macula, patient will lose vision. So around this area in all quadrants we are applying burns which are, we are not applying confluent burns. If we apply confluent burns, then the patient's peripheral vision will go completely, so we don't want to aim for that. What we are doing is we are applying burns one width apart. For example, if the spot size is around 500 micrometers, so we are applying one spot here, then we have to leave a gap of 500 micrometer and apply another spot. So one burn, the distance between the two spots is equal to the size of the spot. So equally spaced laser spots of lasers are applied all over the retina. So that is the basic funda of pan-retinal photocoagulation. And in vitreous, so what we do here, if a patient has PDR, we apply the laser and laser will act and the PDR will regress. The blood vessels which have grown into the vitreous will regress. They will get fibrous. So we have to wait, say, for 4 weeks or 6 weeks. We have to observe, and if we feel that still we can see new blood vessels, then we can apply additional laser. And basically pan-retinal photocoagulation, we don't apply all burns in one stage. We do it in stage-wise process. First we apply the burns inferiorly, because then if vitreous hemorrhage occurs, then it will settle inferiorly. So later on the treatment of inferior area is difficult. So pehle we apply the burns inferiorly, then superiorly, nasally and temporally. So we apply it in almost 3 stages, and we have to apply 500 spots per stage. So around 1500 spots of laser we apply in pan-retinal photocoagulation, right? And then we observe the patient. If we feel that the PRP is sufficient, then we don't do additional laser. So how do we know that? We can see the retina. If the retinal new blood vessels are regressing in size, then we just observe the patient. If it doesn't happen, then we apply additional laser, right? And this is a fresh picture. After maybe within 1 week the picture has been taken. So once the scars form, it forms nice pigmented scars, this PRP or pan-retinal photocoagulation. Sometimes despite best efforts, the retina gets detached in PDR, or there is formation of epiretinal membrane above the macula, on the macula. So in these stages, what we have to do is we have to remove the vitreous. We have to do vitrectomy, and once we do vitrectomy, then we can apply the laser inside with here we can see that there is a endo laser probe which is applying laser directly on the retina, so that we have to apply. So what are the indications of vitrectomy in diabetes? Basically, friends, if the vitreous hemorrhage is not resolving, then we have to do vitrectomy. Or if there is formation presence of tractional retinal detachment, or if there is formation of epiretinal membrane, then we have to do vitrectomy. So what is the conclusions? Conclusion of this lecture is diabetic retinopathy is preventable through strict glycemic control and annual dilated examinations by ophthalmologists. So friends, I hope you have understood the basic funda of treatment. पहले तो prevention is most important than cure. So we have to control the diabetes strictly. Then we have to control the comorbidities, regular eye checkup. So these are the 3 or 4 points that are required, that are in the prevention. Then once the disease sets in or disease becomes severe, it reaches proliferative stage. So proliferative stage में patient आता है आपके पास, तो we have to do pan retinal photocoagulation. And if this pan retinal photocoagulation fails, then we have to do vitrectomy. And if there is maculopathy, either we can do laser or we can give injections. And this injection of this Avastin, what we have to do is, how do we decide when to give injection or how to give injection? So once we see the patient has a diabetic macular edema, then we do OCT or ocular optical coherence tomography of that patient. We check the thickness of the central part of macula, and if it is above 500 micrometer, then we decide to give an injection. And once we give injection, then we observe the patient. We repeat the OCT after 1 month, and if we feel that the macula has flattened significantly or completely, then we just observe the patient. But if we feel that the macula is still there is some edema, then we again inject. So patients will require multiple injections. And if we don't get any response by Avastin in first injection, then we have to try some other injection, like we have to try another VEGF inhibitor, that is Lucentis. And if it also fails, then we can inject steroid in the eye. That ocular triamcinolone injection can be given, but it has got side effects like glaucoma or cataract. So first we want to give only Avastin. And because this Avastin is so wonderful drug, now the laser in diabetic maculopathy has taken somewhat backstage. Means if there is only localized leakage, we do laser. But if the leakage is diffuse, if there is diffuse macular edema, we prefer injection. So this is how we treat diabetic maculopathy. And the investigations that are required in treatment of diabetic retinopathy, apart from the normal investigation, like we have to check the blood sugar, then we have to check creatinine, because the patients may have renal changes also at that time. Then we have to do dilated fundus examination, and then we can do fundus fluorescein angiography. It is similar to cardiac angiography, wherein we inject a dye into the patient's vein, and we take fundus photographs of retina with a special fundus camera which has got multiple filters. So that is how we check this fluorescein, and we take the pictures and we see whether there is leakage or whether there is ischemia, which we can see very clearly on FFA. And OCT will tell us whether there is any structural abnormalities in macula, whether there is any macular swelling or cysts in the macula. So these two are very important investigations in diabetic retinopathy nowadays, that is fluorescein angiography and OCT. And patients with diabetes may also have glaucoma because of neovascularization, so it is very important to check the intraocular pressure also. Some patients with diabetes may have dry eyes or frequent change of refractive error. Some patients may have cataract. So these are the other things that are present in diabetes. Okay. So that is all about diabetic retinopathy, friends. If you have any doubts, you can always ask me. And if you want anything to be covered in diabetic retinopathy, please let me know. I will. You can formulate the questions, so I can just take a lecture on. I can just take a question answer session next time. Thank you so much.